Thank you, chairpersons. Thank you, Dr. Manoj, Dr. Purvi, and the entire team for inviting me over here to speak on a very pertinent and very important topic as of now, that is weight reduction. We all know that every diabetic patient suffer from obesity, and not only diabetic, anyone who is having a metabolic syndrome, they also suffer from obesity. And when the present buzz is about weight reduction using pharmacotherapy, the latest GLP-1s and whatnots, the GIP and the GLPs, so why not we go back to our ancient times? Why not we go back to our rules when our rishis and munis, how they achieved their metabolic health? So something can be done over there also. So I will be highlighting mainly on that aspect today. We all know what is the aim of every physician is to control a good blood sugar, to minimize hypoglycemia, and delay the long-term complications. And the energy requirement of an individual depends upon his age, the sex, the physical activity, and the body weight, of course. And the typical diabetic diet, which every one of you know, I just highlight that carbohydrates should be in the range of 50 to 55%, proteins around 15 to 20%, fat should be around 20 to 30%. And this is a typical diabetic plate, which you all know, that half of the plate should be of vegetables, 1/4 should be of meat alternative, meat, fish and all, and the other should be of grain, that is carbohydrates. And what are carbohydrates? They are the most important essential macronutrient from which we derive the glucose, on which the body runs the final ATP molecule. And these are the sources of carbohydrate: the starch, the rice, the cereals, breads, fruits, fruit juices, vegetables, dairy products, desserts. They contribute to our carbohydrate load. And of course, among the food, we have some food which are not very rich in carbohydrate, like dark leafy green vegetables, tomato, broccoli, and cauliflowers. And fats, of course, they give less of carbohydrate, the oils, the nuts, butters. Then proteins, also they contribute less of carbohydrate, more of proteins. And this is a typical diabetic person, which in a very simplified form, we can say the rule of palm. One palm, the size of a palm should be either fish or mutton. The other palm should be the size of a vegetables and fruits. Very simple. The thumb should be your cheese. The size of a tennis ball is the rice or the carbohydrate. And the size of a golf ball is the amount of butter which you can take, or peanut butter as of now. So a very simple portion meal, how every diabetic patient can be made to understand how to minimize and how to go about a diabetic diet. This I find very practical, and I put it up in many of my talks whenever I give on this food, a very practical way how to make every diabetic patient understand their diabetic diet. So as of now, the budget is to reverse or make the diabetic go into remission. And the methods which we follow is bariatric surgery, very low calorie diet and low carbohydrate, or the ketogenic diet, which we all prescribe to a patient. So in that, how can we achieve these modalities? One is intermittent fasting. This intermittent fasting, we all know, is the most widely searched article as of now on the net, and it has been trending, and the search is going bigger and bigger with every passing day. So is intermittent fasting and starvation the same? Of course not. For starvation is extreme form of fasting which can result in degeneration and death. But intermittent fasting is not starvation. So both are different. And today, Dr. Peter Schwartz, IDF president, has laid a lot of stress on fasting. And he has specifically mentioned about intermittent fasting. Now they are going to come out with the latest recommendation of IDF, how to fast and what fasting benefit can give to everyone, especially the diabetic patients. So intermittent fasting, we usually fast for about 16 hours a day, and 8 hours we take our normal reduced meal. We can fast for 5 days, and 2 days we take our normal meal. So alternate day fasting, we can fast one day and take the normal diet on the other day. So these are the various modalities how you go about intermittent fasting. And the basic pathophysiology, how it works. Once you eat food, it releases insulin. Insulin stores fat in the liver and sugar in the liver. But if you are fasting, there is no release of insulin. So the body burns the body fat either in the liver or in the viscera. So inside our body, we know we derive energy from two sources. One is the glucose and other is from the fat. The basic idea of intermittent fasting is to allow the insulin level to go down far enough and for long enough so that we burn off our fat. Means we want our body metabolism to switch from glucose to fat metabolism. This is the metabolic switch, a very wonderful coined term, the metabolic switch. And this metabolic switch was being practiced by our ancient, the cave dwellers. When they used to go out for hunting, they eat food on one day and then they used to go on fasting for about a long period of time, maybe for more than one day also sometime. So they switch their body metabolism from the glucose to the fat metabolism. So, and in the process, they get these ketone bodies. And this metabolic switch is very important for a good metabolic health of the body. And in our present context, when we take meal about 3 to 4 times a day, we don't allow our body to have this metabolic switch from glucose to fat metabolism. And this is the main result, this is the main reason why you are having all these metabolic syndromes as of now. And the recent surge which is there, the obesity, metabolism, all this because we are not allowing the body to go into its old form of metabolic switch. And the proofs are there. If you search the PubMed and all, you will find enough of articles are there as of now that the body needs ketones as the preferred fuel for both the brain and the body. The brain derives 40% of its energy from ketones, but by not allowing our body to produce ketones by means of fasting, we are depriving the brain of its ideal fuel. And that is the reason for all the neurodegenerative disease which have been of late has picked up momentum. So we want some ketones to be produced by the body for a good neuro health, for a good metabolic health. And comes the autophagy. We all know the famous Japanese scientist who was awarded the Nobel Prize, Fusuhiro, who was awarded this Nobel Prize in 2015 for autophagy. What is autophagy? Autophagy is just cleaning of the natural cleaning of your body. The body cleans of its neurotoxins, the dead cells, the cancerous cells which are about to begin, they can be cleaned off if you allow autophagy to happen. And how to allow autophagy to happen? Fasting is the best way. You fast for more than 17 to 18, by 17 hours, autophagy sets in and it peaks by about 25 hours. So if you allow your body to fast for more than 17 hours, you are allowing autophagy to happen, and this autophagy will cleanse your body. It will cleanse of all the unnatural cells, the dangerous cells, the cells which are progenitor for the cancerous cells. They can be cleaned up by autophagy. So these are the various means by which we can clean our body. But intermittent fasting is not for everyone. It is not for the diabetic patient, of course. It is good for those who are pre-diabetic, those who are in dysmetabolic, but not for diabetic patients. And old age, the children having low blood pressure in the conceiving period, so they can't go. So this is more of prevention. This is more of, you can use it for preventing the metabolic disharmony before it sets in your body. Now coming on to very low calorie diet. Very low calorie diet, of course, can be done by the diabetic patients also. Here you take less than 900 calories per day for 3 months, and you derive and you make the body utilize body fat so that ketone bodies are produced. And it has been seen that diabetic reversal and remission by using a ketosis diet, you can reverse diabetic by about almost 55%. You can go make diabetics remission to the tune of almost 19%, and complete remission can be achieved to a tune of almost 7% by going in for low carbohydrate nutrition that is less than 800 to 900 calories per day. The data is in front of you. These are the results. And what is low carbohydrate nutrition? Low carbohydrate nutrition is nutrition below 50 grams of total carbohydrate per day. You must push it, if possible, push it down to less than 30 grams per day. Because in 30 grams, you get the ideal ketosis, which the body needs. And moderate amount of protein, fat should be the primary source. Dietary fats include saturated, monosaturated, and polysaturated fat. So less than 50 grams, you go into ketosis. But ideal should be below 30 grams. 50 to 100 grams, that is less than 30% of a calorie, that is low carbohydrate, but not ketogenic unless you supplement with exercise or other physical activity. Anything more than 30% of a total calorie is not low carbohydrate diet. And this is how typical ketotic regime is followed. There's the induction phase, there's a weight loss phase, the pre-maintenance and the maintenance phase. You see, if you take the total body expenditure of 2,400 calories, you are supplementing only 1,300 calories by means of food. And of that, 820 calorie is coming from fat, 120 is from carbohydrate, and 360 from protein. So this difference between 2,400 to 1,300 calorie is being utilized by the body, is made up by the body from the body fats. And in the process of burning fat, the body will generate ketones. And this is how you go into induction of ketotic regime. Then after this, you follow the weight loss. Here you become more stringent. You give him 1,500 calories, or you cut down the calorie intake more, and you give him 1,500 calories, and the gap will be from the fat loss, from the fat of the body. Then you go into a pre-maintenance, in which you cut it down more to 2,050 calories, but you are increasing the fat diet slowly and slowly. And in the maintenance phase, you cut down the calories to 2,000, which I think is a very good calorie requirement for every one of us. We don't exercise, we don't have too much of energy requirement. And of this, the maximum is being contributed by fat, which is 1,400 calories, 240 from carbohydrate, and 360 is protein. If you see, the calorie from the protein is almost same always in all the three phases. So this is how you go into nutritional ketoacidosis. And ADA has also have given its stamp on this, that low carbohydrate eating patterns, especially very low carbohydrate diet, has been shown to reduce HbA1c and the need for anti-hyperglycemic medications. These eating patterns are among the most studied eating patterns for type 2 diabetes. This eating pattern does not appear to increase overall cardiovascular risk. This is the ADA statement of this. And these are the old scientists who followed this ketotic diet before the advent of insulin and OHS. This is a typical diet chart which was prescribed to the diabetic patient, and see how ketogenic it is. So we are going back to our basics again. And this is the difference between a glucose intake and a fat diet. You can see the amount of glucose surge which is there with a carbohydrate diet. And why we are getting the benefit? It is because of the beta hydroxybutyrate inhibit oxidative stress and inflammation. And we all know that diabetes is an inflammatory disease, and beta hydroxybutyric acid cuts down this inflammation. There are many articles. I am running short of time, so I will not go through all these articles which are there. I will just highlight this VITRA IUH clinical trial, which is just 1 minute more, which is a 5-year non-randomized prospective controlled trial. For almost 465% took part in it, and the patients were given the continuous care intervention or the usual care, and see the results. The patients were all diabetic, they were obese. See the results. 13% improvement in blood glucose improvement, medication reduced was 94%, weight loss was 12%, CVD risk reduction was 12%. You see, more the higher the HbA1c in the beginning, better is the result. You see the amount of improvement in the medications. 67% of all diabetic prescription eliminated, 100% of sulfonylurea prescription eliminated, 91% of insulin prescriptions reduced, 81% of mean reduction in insulin dose. So these were the results in diabetic patients who were put on ketogenic, low carbohydrate diet. They were obese and diabetic, and see the results. We are cutting down all the medications. And see the weight loss, 12%, sustained at 2 years. Most important, it is being sustained over 2 years. So you are getting the same result which the pharma companies are claiming as of now by the use of GLP and the GIP. You are getting the same thing if you need to have some discipline in your life only. And
we are running short of time. Yeah. Please summarize.
We get benefit in sleep apnea. We get benefit in NAFD also. And this is a conclusion. So carbohydrate restriction is a viable patient choice for type 2 diabetes. Nutritional ketosis supports diabetes reversal by reducing insulin resistance and in providing an alternative fuel to glucose. Low carbohydrate nutrition pattern including ketosis and extensive clinical trial evidence of type 2 diabetes improvement. The ADA and other organizations have updated their guidelines to include low carbohydrate eating pattern, and that was what today Dr. Peter also told the same thing, and we need to monitor these patients carefully in the long run. So thank you everyone for your patient hearing.